Hello everyone. In this lecture, we are going to discuss about fluid and electrolyte imbalance. Before going to the topic in detail, we are going to first introduce different terminologies related to body fluids. They are intracellular fluid, extracellular fluid, osmosis, solute, osmolality, diffusion, filtration, and active transport. Okay, now what is intracellular fluid? It is also called ICF, intracellular fluid. It is found within the cells of the body and it constitutes two-thirds of the total body fluid. In adult, its major cations is potassium. Potassium is regarded as the major cations of intracellular fluid. Now we come to the extracellular fluid. Extracellular fluid, and it is found outside the cells and it accounts for one-third of the total body fluid, and the major cations of extracellular fluid is sodium. Sodium is regarded as the major cations of extracellular fluid. Now we come to osmosis. Osmosis is the movement of water across the cell membrane from less concentrate to more concentrate. When the water or the solute moves from the lower concentration to the higher concentration, the process is called osmosis. Now we come to solutes. Solutes are the substance that dissolved in a liquid. We can say it may be a sugar, salt, for example, sugar, salt, they dissolve in the liquid. So they are called solutes. Now we come to osmolality. Osmolality is the concentration within the fluid. The concentration, for example, the concentration of sodium in the fluid is called the osmolality of sodium. Okay, now we come to diffusion. Diffusion is the movement of molecules in liquid from an area of higher concentration to lower concentration. Okay, osmosis and diffusion are opposite to each other. Diffusion means the movement of molecules. The molecules in the liquid move from higher concentration to the lower concentration. Then this condition is called diffusion. And the next one is filtration. The fluid and the solid move together across a membrane from area of higher pressure to one of the lower pressure. Then this condition is called filtration. And the last one and the final one is active transport. The substance move across the cells membrane from the less concentrated solution to more concentrated requires a concentrated solution is called active transport, and it requires a carrier. Okay, with this we are here for with the terminologies of body fluids. Now we go to the next slide, and the next slide is the fluid basics. Let's discuss, or let's have the overview of fluid basics in our body. About 60% of our body weight in male and 55% in female body weight contains water, and among them 40% is intracellular fluid, while the 20% is extracellular fluid. And extracellular fluid constitutes of the interstitial 15% and intravascular 5%. And the fluid and electrolyte balance is extremely complicated thing, but knowledge of fluid and electrolyte is very important in management of patients. So we are going to discuss the fluid basics also. Okay, now let's go through the fluid spaces also. There are first spacing, second spacing, and third spacing. First spacing means the normal distribution of the fluid. Normal distribution of the fluid in the intracellular and extracellular fluid is called the first spacing, and second spacing is the normal accumulation of the fluid in the interstitial spaces or the interstitial fluid. Then it is called second spacing. We also give it term called edema. And next one is third spacing. Third spacing is the fluid accumulation in the part of the body where it gets trapped. It gets trapped and it cannot exchange. The fluid cannot exchange with the extracellular fluid. Then this condition is called third spacing. For example, in ascites. Okay, now let's have a overview of the water requirement, normal water requirement also. Normally 2 liter of water, that is 2000 ml of water is required. Generally, it is regarded as sufficient for adult for 24 hours, and most of the intake is usually derived from the water content and of food and water of oxidation. Therefore, it has been estimated that only 500 ml of water needs to be imbibed in given normal diet and in no increased losses. And the sources of water are markedly reduced on the patient who are not eating and so must be replaced by the maintenance fluid. If, for example, if patient are on NPO and if the dietary pattern has been altered and if patient doesn't take the proper amount of food, then we have to provide the fluid replacement to the patient. The water requirement it increases with the different condition. For example, in fever, sweating, burns, different types of traumas, tachypnea, surgical drains, polyuria, and ongoing significant gastrointestinal losses. For example, water requirement increased by 100 to 150 ml per day for each degree centigrade of body temperature elevation. In fever, we required more water. Okay, this is the normal intake and output of fluid in a healthy adult. Now we have come with the end of generally a brief review. Now we will be discussing about the fluid imbalance. The fluid imbalance may be either due to fluid deficit or fluid excess. If the amount of fluid in our body is more, that means excess, and if it is less, it means deficit. Then the both conditions are regarded as the fluid imbalance. Okay, let's go through the fluid volume deficit. Fluid volume deficit means the amount of fluid is less. Okay, first of all, hypovolemia. The loss of both water and electrolyte from the extracellular fluid is called hypovolemia, and its causes includes increased output, hemorrhage, vomiting, diarrhea, and burns, or fluid shift out of the vascular space, that is third spacing, into the interstitial space. This can also cause hypovolemia. We can see here in the figure as well, a patient is vomiting, diarrhea, these are also the causes. And here we come, GI suctioning, interstitial fluid, and intestinal drainage. Similarly, diuretic therapy, chronic abuse of laxatives and enemas, these also can cause hypovolemia. And renal disease, if a patient has a renal disease, then hemorrhage. Okay, here we see the example of third spacing, shift of fluid from the vascular space to the abdomen or pleural or peritoneal space. Okay, we can see here the abdomen is swollen due to the accumulation of the food, which is also called ascites. Okay, for when we assess the patient of hypovolemia, we see the different clinical manifestations in the patient. We go through the system wise. First one is the cardiovascular system. Here we see the diminished peripheral pulse, thready pulse, decreased blood pressure and orthostatic hypotension, increased heart rate tachycardia, elevated hematocrit level, and in the similarly in the gastrointestinal system, we see the patient having thirst, decreased motility, diminished bowel sound, possible constipation as well. Similarly, in the neuromuscular system, decreased CNS activity, and patient may become lethargy and to coma, and skeletal muscle weakness. And in integumentary system, dry mouth and skin, poor turgor of the skin, and pitting edema, and sunken eyeballs. Eyeballs will be seen, sunken. And in the renal, decreased urinary output, decreased specific gravity of the urine, weight loss, and hypernatremia. Hypernatremia means the amount of sodium, the concentration of sodium in the blood will be increased. We will be discussing in detail in later. And next one is in respiratory system. It increase the rate and depth of respiration, and possible patient may also have fever. Okay, well, assessing the fluid balance of the patient, we will be assessing like this. The skin with decreased turgor remains elevated when we pinch it with the two fingers, thumb and the index finger. Then um, if the and it goes back very slowly, and if the patient is dehydrated, we can also assess through the tongue. Dry of the tongue can be seen. Okay, now intervention for the fluid volume deficit hypovolemia. We have to, these are the nursing measures. We have to prevent the further fluid loss, and other rehydration therapy can be done. IV therapy with colloids and crystalloid blood transfusion can be performed if the patient is having hypovolemia through hemorrhage, and medication such as antiemetic if the patient is having vomiting, and antidiarrheal if the patient is having diarrhea, and vasopressors if the patient is in shock, cause vasoconstriction and increase the BP. We can use the medicines like adrenaline, isoprenaline, and dovitamin, which are the choice of medicines. And we have to monitor the cardiovascular system, vital signs of the patient, respiration, renal, as well as GI status. We have to strictly monitor the intake and output of the patient. Similarly, here is we have to monitor the electrolytes. The electrolytes possible supplementation have to be done. Supplementation treatment have to be done if there is any alteration in the electrolytes level. And we have to monitor the intake and output as well as weight strictly. Now, next topic is the fluid volume excess. Fluid volume excess, here is the hypovolemia condition. The fluid overload is an excess of the body fluid over hydration of, and the excess fluid volume in the intravascular area, which is called over hypervolemia, and the excess fluid volume in the interstitial space is called edema. And these all result from the water and sodium retention in the body. Sorry. Now, the causes of fluid volume excess: increased sodium and water retention in the body, and in excessive intake of the sodium, that may be per oral or intravenous route, and excessive intake of the water, which can also be from per oral or intravenous route, and which causes the water intoxication, and syndrome of appropriate antidiuretic hormone. Excessive release of ADS from the pituitary gland leads to the increase in sodium and water retention, which can also cause hypervolemia. Similarly, renal failure, congestive heart failure, and cirrhosis of liver can also lead to hypervolemia. Okay, we can see here the figure of a healthy liver and a cirrhosed liver. Corticosteroid administration, sodium containing drugs and food also cause hypervolemia. Similarly, adrenal gland disorders like Cushing syndromes can also cause hypervolemia. And we come with the sign and symptom of fluid volume excess. Excess fluid in the interstitial space is seen. Similarly, peripheral edema is seen. We can see here in the figure, and generalized edema, which is also called the term anasarca, can be seen in the patient. Okay, here are also the sign and symptom of fluid volume excess: coughing, pleural effusion, excess fluid around the lungs, swelling in the abdomen, which is called ascites, swelling in the ankles and the legs, peripheral edema, pumping action of the heart grows weaker, pulmonary edema, excess cold fluid in the lungs, tiredness, and shortness of breath. Weight gain is more than 5% of the body weight, and rise in blood pressure is also seen as a sign and symptom of fluid volume excess. And we have already discussed the pathophysiology of how the blood pressure gets a rise due to fluid volume excess. Let me review once again. And the blood pressure, it is directly affected by the cardiac output, and the cardiac output will be increased if the volume and the peripheral resistance will increase. So if the volume of blood is increased, then automatically it gives rise to the blood pressure. Okay, for the diagnostic investigation of fluid volume excess, we can determine through the serum creatinine level, blood urea nitrogen, uh, liver enzymes, ECG or echo. Now here are the different clinical manifestations when we perform the assessment, nursing assessment of patient with hypervolemia. In the cardiovascular system, the elevated bounding elevated BP, distended neck veins and head veins, ventricular gallop, that is S3 sound is heard, which is the abnormal sound, usually not heard in the normal condition, and hyponatremia in the GI, increased motility, stomach cramps, nausea and vomiting in respiratory system, dyspnea, crackles and tachypnea in renal system, weight gain, decreased specific gravity of the urine in integumentary system, periorbital edema, pitting or non-pitting, edema in neuromuscular system, altered loss of consciousness, headache, skeletal muscles, twitching can be assessed. Okay, this is the figure showing the periorbital edema, jugular vein distension, neck vein distension, and the peripheral vein are also distended here. We can see assessing the fluid balance, monitoring the weight of the patient. Now, what are the nursing interventions for hypervolemia? We have to restore the normal fluid balance and prevent the further overload. We can also use the drug therapy like diuretics, diet therapy. In diet therapy, we have to decrease the sodium and fluid in the diet and monitor intake and output strictly and monitor weights. Similarly, we have to monitor the electrolytes level. We can do that through the blood investigation, blood test, electrolytes, and monitors cardiovascular system, vitals, respiration and renal system, and we have to strictly monitor the intake and output. Okay, when we are giving the patient with the diuretics therapy, then we have to provide the patient and family teaching regarding its duration, time of intake. That is, diuretics are usually prescribed morning and afternoon because it increases the urinary output, and patient might feel difficulty when it is prescribed at night. So, and changing position slowly, similarly weighing himself or herself daily and avoiding the salt shakers and the processed food, and potassium rich food has to be advised because potassium it decrease the effect of salt in the body. Okay, now we come to the electrolytes. Electrolytes are the elements or the compounds when dissolved in the water will dissociate into ions and are able to conduct an electrical current. There are different types of electrolyte in our body. We will be discussing them. Now the function of electrolytes are to regulate the fluid balance and osmolality, transmission of nerve impulses, stimulation of the muscle activity and muscle contraction, blood clotting, regulate enzyme reactions, through ATP formation and regulate the acid-base balance. Okay, electrolytes can be divided as cations and anions. Cations are the positively charged electrolytes. Sodium, potassium, calcium, and magnesium fall under this category, and anions are the negatively charged electrolytes. Chloride, phosphate, bicarbonate, and bicarbonate, that is HCO3, fall under this category. Okay, electrolytes. We can see here the distribution of body electrolytes. Intracellular are the potassium, magnesium, phosphate, sulfate, and protein, and extracellular are the sodium chloride, bicarbonate, and calcium. And the major intracellular cations is the potassium, and the major extracellular cations is the sodium. Okay, sodium, it is 90% of the total extracellular fluid cations is sodium. Its normal value is 135 to 145 MEq per liter, and it is low in intracellular fluid. Reabsorption in the renal tubule is regulated by the aldosterone, renin, angiotensin, and arterial natriuretic peptide ANP reabsorption of sodium. Now, the function of sodium is to assist in the nerve transmission and muscle contraction, major determinant of extracellular fluid osmolality, and primary regulator of extracellular fluid volume. And it is most important ion in regulating the water and body fluid balance. Now we come to the abnormal condition of sodium, that is hyponatremia. When the sodium level is less than 120 MEq per liter, it is called the condition hyponatremia. Its causes are losses of body secretion due to vomiting, diarrhea, burn, gastrointestinal suctioning, and excess antidiuretic hormone ADS secretion, which can cause dilution hyponatremia, and excessive administration of hypotonic intravenous solution can also cause hyponatremia. Hormonal imbalance causes more loss of sodium and insufficient aldosterone secretion, and diuresis, and excessive water intake can also cause hyponatremia. Okay, here are the symptoms of hyponatremia. Early symptoms are nausea, vomiting, anorexia, abdominal cramping, weakness, and fatigue. And the later signs are altered neurological functions such as confusion, lethargy, convulsion, coma, muscle twitching, tumors, dull sensorium, irritability, personality changes, cerebral edema, headache, weakness, and seizures. We can see here in the picture, cartoonized picture, for the clinical manifestation of hyponatremia: headache, muscle weakness, fatigue, apathy, postural hypotension, nausea and vomiting, abdominal cramps, and weight loss. In severe hyponatremia, mental confusion, delirium, shock, and coma can also be seen. Okay, now the treatment of hyponatremia. Hyponatremia caused by excessive dilution. We have to treat with the loop diuretics to cause an isotonic diuresis, and hyponatremia that is caused by the sodium loss. We have to treat with the oral sodium chloride or intravenous fluid containing salt. For example, normal saline can be given and ringer lactate can be given. Replace the isotonic fluid, that is normal saline, and observe for the sign and symptom of shock and renal failure. Now, next condition is hypernatremia. When the amount of or the concentration of sodium is more than 145 MEq per liter, the condition is called hypernatremia. Here are some of the causes: renal disease, excessive saline intake, elevated serum sodium occurring with water loss or sodium gain, decreased thirst, brain injuries, burns, infections, high fever, failure to communicate for need of water, etc. And it can also be caused due to the excess sodium intake, that is hypertonic IV solution, excess sodium retention, oversecretion of aldosterone, loss of pure water. For example, long term of sweating with chronic fever, respiratory infection, water vapor losses, and in diabetes mellitus or insipidus due to polyuria, and in hypodipsia, insufficient intake of water. These are some of the causes due to which hyponatremia can be caused. Okay. Now, the sign and symptoms of hypernatremia. Hypernatremia is generally asymptomatic, although mild cases can result in excessive thirst. Okay, excessive thirst can be regarded as the major clinical symptoms of hypernatremia, and which is commonly seen. And however, in severe cases, progression of symptoms can result in weakness, lethargy, irritability, confusion, coma, and seizure. And in case with sodium more than 120 MEq per liter, neurological defects can appear, including ataxia, tremor, coma, and seizure. Okay, now what are the management of hypernatremia? Serum sodium level must be reduced gradually to avoid the cerebral edema. Treat the underlying cause. If oral fluid cannot be ingested, use isotonic salt-free IV fluid. IV solution of 5% dextrose in water, a hypotonic saline can be used. Antidiuretic hormone injections or the nasal sprays can be used. Now the next electrolyte we come through is potassium. It is a major cation that is present in the intracellular fluid. Almost 80 to 90% of the potassium excreted is normally excreted in urine, and its normal value is 3.5 to 5.5 MEq per liter. Its functions are to regulate the intracellular osmolality, helps to promote the heart muscles activity, nerve conduction and muscle contraction, metabolism of carbohydrate, fat and protein, and it fosters the acid-base balance. Okay, we can see here the major sources of potassium that are fruits and vegetables, salt substitutes, potassium medications, and stored blood. Okay, now we come to the condition hyperkalemia, in which the level of level of potassium is more than 5.5 MEq per liter. Here are some of the causes: the poor potassium output due to renal failure, massive intake, excessive release of potassium from cells following the burns and injuries. Following the burns and injuries for 24 to 72 hours, the cells will be releasing the potassium is a compensatory mechanism which can lead to excessive hyperkalemia. A compensatory shift from intracellular fluid to extracellular fluid in acidosis, and therapy with potassium sparing diuretics and ACE inhibitors can also lead to hyperkalemia. Now we come to the signs and symptoms of hyperkalemia. The most serious manifestations are the muscle weakness or paralysis, cardiac conduction abnormalities, and cardiac arrhythmias. If the level of potassium goes above 7.0 MEq per liter, and ECG abnormalities can be seen. Other manifestations are polyuria, polydipsia with uncontrolled diabetes. And severe muscle weakness or paralysis. Hyperkalemia can cause ascending muscle weakness, which have the typical features that begins with the leg and progress to the trunk and arms, and this can progress to flash sheet paralysis mimicking GBS, that is Guillain-Barré syndrome, and the manifestation resolves with correction of hyperkalemia. Once the hyperkalemia is treated, the manifestations also gets resolved automatically. Now, for the management, we can also restrict the oral or the parenteral fluid and foods containing the potassium, increase the elimination of potassium through the use of diuretics or dialysis, force potassium from extracellular fluid to intracellular fluid by IV insulin, dextrose and dextrose infusion. And for the temporary corrective measures or the emergency management, we can use the antidote calcium gluconate. It reverses the membrane effect of elevated extracellular fluid potassium. And we can also use the insulin and glucose or sodium bicarbonate to promote the potassium uptake in the cells. These are the temporary corrective measures or the emergency measures. Now we come to the next condition, that is hypokalemia. When the level of potassium is less than 3.5 MEq per liter, the condition is called hypokalemia. And some of the causes are inadequate intake of potassium due to poor diet or poor appetite, chronic administration of diuretics, excessive loss of potassium due to diarrhea and vomiting, abnormal loss of potassium via kidney or gastrointestinal tract. Here we come through the sign and symptom of potassium deficit: alkalosis, shallow respiration, irritability, confusion, weakness, arrhythmias, lethargy, steady pulse, and decreased intestinal motility. And the other signs and symptoms are malaise, complaint of general weakness, weakness of the muscles of heart, intestinal and respiratory muscles. For the management, KCl supplements should be provided orally or through IV fluids, and we should not access 10 to 20 MEq per hour in order to prevent hyperkalemia and cardiac arrest. So we usually administer potassium by diluting in the IV fluid and give it over 6 to 8 hourly. In practical basis, we have to encourage the patient to take high potassium diets such as banana, orange, coffee, and meat. Now next, we come to the next electrolyte, that is calcium. And about 99% of calcium concentrated in the bone and teeth, and it is closely associated with phosphorus, and they are regulated by the parathyroid gland. And the normal value of calcium is 4.5 to 5.5 MEq per liter. And its major function is the formation and mineralization of bones and teeth, muscular contraction and relaxation, cardiac function, blood regulation, and promote absorption and utilization of vitamin B12. Okay, here is the condition hypocalcemia. When the serum calcium level is less than 4.5 MEq per liter, then we call the term hypocalcemia. The poor dietary intake of calcium, disorders such as hypoparathyroidism, poor vitamin D intake, and absorption can lead to hypocalcemia. The sign and symptom of hypocalcemia are tingling around the mouth or in the extremities and numbness of fingers, spasm of muscles, tetany and convulsion, decreased cardiac contractility, positive torsius or the Chevotex sign, and the laryngeal stridor and dysphagia. Okay, Chevotex sign. We can see here in the video.
Trostick sign is a clinical sign of facial nerve hyperexcitability, also known as tetany, that is seen during times of hypocalcemia, which can result from hypoparathyroidism, pseudohypoparathyroidism, vitamin D deficiency, etc. When the facial nerve is stimulated due to tapping at the angle of the jaw, the ipsilateral or same side masseter muscle will contract. Now the practitioner will demonstrate Trostick sign on this patient.
Okay. These are the tests for hypocalcemia. We have just seen the Chevotex sign. And the next one is Torosius sign. Let's see.
Trousseau sign is a clinical manifestation of hypocalcemia that is more sensitive than Trostick sign. To elicit Trousseau sign, occlude the brachial artery using a blood pressure cuff. The lack of blood flow exacerbates the existing calcium deficiency in the neuromuscular tissue of the distal arm, causing spasms of the hand and forearm muscles. This leads to wrist and metacarpal phalangeal joint flexion, proximal and distal interphalangeal joint extension, and finger abduction. As we occlude the blood vessel, notice the patient's hand turning upward and inward, flexion and deduction.
Okay, for the management of hypocalcemia, we can provide the IV administration of 10% calcium gluconate slowly for tetany and convulsion. High calcium diet can be provided, and administration of parathyroid hormone or for hypoparathyroidism can be done. Now we come to the next condition, that is hypercalcemia. When the serum calcium level is more than 5.5 MEq per liter, the condition is hypercalcemia. Here are some of the causes of hypercalcemia, that is overactivity of the parathyroid gland, overconsumption of the milk, minerals, and vitamin D, decreased secretion of calcium, excessive movement of calcium out of the bones, and vitamin D overdose, prolonged immobilization. Now, some of the silent symptoms of hypercalcemia are bone pain, osteoporosis, pathological fracture, renal stones, kidney infection, decreased memory, confusion, disorientation, fatigue, and constipation. We can see here in the cartoonized picture the clinical manifestation of hypercalcemia. Now, for the management of hypercalcemia, excretion of calcium with loop diuretics can be done. Hydration of isotonic saline infusion. Synthetic calcitonin can be provided. Restriction of the calcium intake. Treatment of parathyroid disorders, and mobilization can be done. And the next electrolyte is the bicarbonate, that is HCO3. Its normal value is 22 to 30 millimole per liter, and it acts as a buffer to maintain the normal level of pH in the blood and other fluid in the body. And it is measured to monitor the acidity of the blood and the body fluid. Bicarbonate deficit is the condition where the amount of bicarbonate is less than 22 millimole per liter, and the signs and symptoms may be headache, confusion, drowsiness, increased respiratory rate, death, and nausea, vomiting, warmth, flushed skin. And for the general management, bicarbonate replacement can be done and dialysis can be done. And the next condition is the bicarbonate excess, where the level of bicarbonate is more than 30 millimole per liter. The signs and symptoms will be the decreased respiration, muscle hypertonicity, dizziness, tingling of the fingers and toes. For the general management, we can perform fluid replacement if volume is depleted and ensure the adequate chloride intake. Okay, thank you everyone. This was all with the fluid and electrolyte balance, which we have discussed in today's lecture. In the upcoming lecture, we will be discussing more about the different condition related to the urinary system. Thank you for listening. If you have any queries related to this lecture, you can message me in the comment box. Thank you so much.